afternoon and evening, everyone. And I'm Professor Thalangsa, Chair of OSEA. It's wonderful to have you join us from across the regions, and we truly appreciate your time and participation. Today's session is another great opportunity to learn through case-based discussion, highlighting the clinical and pathology correlations we encounter in practice. This discussion is crucial because it allows us to share insights and experiences, enhancing our understanding of clinical cases. Before we begin, I'd like to warmly welcome Dr. Lily Mushaha, who recently joined us as the new Deputy Chair of the ISN OSEA. Dr. Lily is from Hospital Tuanku Jaffa, Negeri Sembilan, Malaysia, and we are very glad to have her with us. Dr. Lily, please say something.
Oh, hi everyone. Good afternoon. Thank you very much, Go, for the kind introduction. I'm Lily Mushaha. So I'm based in Malaysia in Hospital Tuanku Jaffa Seremban. I'm really looking forward to work together with Professor Thalangsa or Golf to develop and also to share more ideas and also in research in the region of Southeast Asia and Oceania. Thank you very much.
And now moving on to today's CPC, I'm pleased to introduce our presenters, Dr. Julia Andres and Dr. Tan Hui Chuan from Singapore General Hospital. They will be presenting a thought-provoking case of an 87-year-old male with hepatocellular carcinoma and nephrotic syndrome. As we move into the discussion, we love for you to join in. If you have questions or comments, you're welcome to type them in the chat or raise your hand to speak. Before speaking, please unmute yourself, briefly introduce your name and where you join from. It's always nice to know who we're learning with. Let's get started. I will over to you, Dr. Andres and Dr. Tan.
Thank you very much. So good morning or good afternoon, everyone. I am Julia from SGH Singapore, one of the renal trainees, and I'm presenting for today's OSEA EPAC meeting, and my supervisor is Dr. Tan Hui Chuan from SGH as well. Okay, so this is the scope of our discussion today. So I'll just dive straight into the case proper. So this is the case that we're discussing today. So he's an 87-year-old gentleman with a significant past medical history of hepatitis B on entecavir, as well as a recurrent hepatocellular carcinoma like HPV related that was ablated in 2009. However, this was complicated by recurrence in December 2023. He was, however, not keen for upfront surgery, and so hence underwent hepatic angiography and the TC99M injection in January of 2024, and subsequently Y90 in February of 2024. He was, however, he did subsequently have recurrent HCC lesions in segment 7 as well as 8 and adrenal metastases, and hence he was commenced on, he was seen by an onco outpatient and offered adjuvant immunotherapy, and he was commenced on tremelimumab and durvalumab dual immunotherapy starting from 17th of September 2024. So this is his initial presentation when we first saw him. So he presented with a rash of 1 month's history. This was started after dual immunotherapy was started for his recurrent HCC in mid-September. And he had this generalized persistent pruritic rash that started a few days after the last dose of immunotherapy. He also complained of a rapidly progressive lower limb swelling for 3 days on presentation that was associated with abdominal distension as well as scrotal swelling. And he also said that he had some frothy urine that started since April 2024, or roughly about 5 months prior to presentation. So on examination, he was noted to have a generalized maculopapular rash over the trunk and back, The lungs were clear, however, his abdomen was distended with positive shifting downwards. He did have edema with lower limb edema to the thigh, as well as scrotal edema as well. So these are the initial investigations that were done on admission, as well as the trend of his previous laboratory tests prior to admission. So you can see the arrow where the immunotherapy was started, and then the subsequent trend of his albumin subsequently, as well as the creatinine on presentation, the urine analysis as well. And then the arrow below, so you can see my code. Okay, it indicates when he was admitted and referred to renal. Okay, so at this point, maybe would anyone like to maybe volunteer and what the whole clinical presentation at this point is pointing to, and what are the possible differentials?
Because we use different units in across the regions, it's possible that you convert to like a creatinine into milligram per deciliter. And for the UA, I'm not quite sure it's a red cell and white cell is a cell per microliter, right? 88 and 8. What is the unit of cell in the UA?
Apologies, I didn't convert it to.
So the creatinine for, as in the conversion for creatinine of 121 micromole per liter is going to be about 1.36.
1.36. Okay,
Yep.
Thank you.
The
And how about
definition,
UA?
UA as in which one? The UPCR. The UPCR is gram per gram.
No. I mean the study for the red cell and white cell is 88
yeah.
cell.
So ours is we are using international units, so we are not per mil. So it's not. I mean, we are using cells per mil, not high power field. Yeah. So our upper limit is 3. 0 to 3 would be normal for RBCs.
So anyone want to be our first volunteer? So raise your hand, unmute yourself. Okay.
Okay, I'm the fellowship from Chulalongkorn University, Bangkok, Thailand. So I would like to summarize the problem list first. So this patient is a 87-year-old male with the underlying of HBV on anti-caviar and recurrent HCC, and he just recently initiated the immunotherapy with temolizumab and durvalumab.
Can I stop you for a while? Introduce yourself first, because you said it's a second year fellow of Chulalongkorn University, right? What is your name, please?
My name is Sarit Puvithiyapan, the first year nephrology
Dr.
fellowship
Sarit,
at Chulalongkorn University.
Right.
Yeah.
Oh,
so the problem list.
Okay. Please continue.
So the problem list of this patient is like he was present with the nephrotic syndrome for like 1 month and the generalized pruritic rash after the third problem list will be the temolizumab and durvalumab recent used for just like 1 month. And the lab investigation of this patient also support the problem list that the patient has a nephrotic syndrome. From the lab show above, like there is a rising in serum creatinine, and also there is a low serum albumin in this patient, and also the UPCR was like 10 gram is in the nephrotic gland, and the patient have a nephrotic syndrome as well. And also the UA show the red blood cell. So this patient has a nephrotic syndrome. So my differential diagnosis first, like I would like to approach from the nephrotic. The cause will be from the immune complex, pulse immune, and anti-GBM. So in this patient, the recent start of the immunotherapy, I recently know that the immune checkpoint inhibitor can cause the glomerulonephritis as well, by way of the immune complex, and also the ANCA can be the cause as well. And also the underlying disease of this patient is the hep B cirrhosis can cause the immune complex as that the person as the MPGN pattern. So the further investigation that I want is to send the complement and also the ANCA and the ANA screening.
Okay. Is there anyone else who would do other tests as well? Besides those that have already been mentioned. Okay. Shall we maybe move on first? Then Julia,
Do you
maybe
have
you can present what
baseline creatinine? Do you have baseline creatinine level?
yeah, so his baseline creatinine will be between 83 to 93. These are quite representative
Okay,
of his
gotcha,
baseline.
That's fine.
Yeah, so
Thank
it's
you.
about 1 to 1.1 milligram per deciliter. Yeah.
So
Okay.
this is Dr. Wing
Anyone
from
else from the other country in the region want to share your idea? Excuse me, can you speak louder? Maybe anyone from Malaysia, or I try to see
Sorry.
Vietnam or something. Actually, I don't know the case. For this case, is a long case or it's short. So if it's short, so I can ask so many people to get engagement.
It's moderately long. It's not too
Moderate.
short.
Okay.
Yeah,
Okay.
it's not too long either. Yeah.
We will allow people to engage. Anyone
I
want
think we have time.
to share your idea? Anyone else? Anyone else? Okay. If
Hello.
no, okay. Hello. Okay. Go
This
ahead.
is Dr.
Go
Win from
ahead.
Chulalongkorn University. I'm a second year fellow. So beyond what Dr. Sarit has well described the differential diagnosis, which maybe we should think of the RPGN mimickers such as acute interstitial nephritis, which can be caused from the immunotherapy that this patient just recently received, and maybe other differentials should include nephrotic syndrome with AKI, because the underlying pulmonary disease of this patient may be just pure nephrotic syndrome, but may be complicated by AKI from the complications such as renal vein thrombosis or AIN.
Okay, I think that's a fair addition. So with regards to that, are you suggesting we do more some form of imaging or additional blood tests? I mean, with your differentials in mind.
Yeah, so maybe we should look at the urine sediment first to determine if the red blood cell in the urine is dysmorphic or not.
Okay. Is there anyone else that would like to add? I think Dr. Quack is also asking.
Maybe I refrain when speaking. So he asked, do you see a glomerular hematuria like a dysmorphic red cell cast or something beside of a red cell and white cell?
So at the start we didn't do a urine phase. And in our urinalysis, there are no casts. Yeah.
Okay, thank you. Maybe can we continue?
Okay, so thank you everyone for your answers. So I'll move on to the investigations that were done on admission. So these were the additional 24-hour urine that we did, which basically showed that the total urine protein was higher than our lab limit. And in terms of the serology done, so you can see that autoimmune ANA anti-dsDNA is negative. Anti-MPO and PR3 were also negative. C2 and C4 were not low. Viral load was 1.02 log, and he was on entecavir. And hepatitis C and HIV were negative. So someone had also volunteered the ultrasound for renal vein thrombosis that was done was also negative. And at the time of the presentation, we also sent off the antibody, but it was pending at the point in time because it's only done once a week in our local institution. Yeah. So these were the investigations done at that point. He was also noted, so when he came, he also presented with rash. So we also got a dermatology review, which basically they did concur and they did feel that there was at least 12% BSA of scattered erythematous scanny macules and papules over the chest, upper and lower back, which were overall in keeping with eczematous drug eruption, secondary to immunotherapy. Essentially a dermatological IRAE to the immunotherapy that was given. So moving on to the interim summary. So at this point in the case presentation, I would summarize this as a patient who presents with nephrotic syndrome, and I say this because he presents with NSACA, progressive hypoalbuminemia over months, nephrotic range proteinuria, with UPCR of 10 and 24-hour UTP above protection limit. That's complicated by KDIGO1 AKI. He also has a secondary issue of a dermatological IRAE with recent dual immunotherapy exposure and recurrent HCC as well. And when we meet him and discussed with him, the patient also shared that he was not too keen for invasive procedures. So at this point, sorry.
Yeah, so maybe I would just take a bit of time to go through the summary as well, because I think we have heard from some of the trainees. I think everybody kind of rightly identified the nephrotic syndrome, but some of us are questioning the significance of the hematuria that was seen, and whether or not is this truly just a predominant nephrotic syndrome with some degree of hematuria on urinalysis, and does that kind of clue us into the different underlying differentials? So at this stage, what I thought was more of a predominant nephrotic syndrome, and I think we have identified the necessary investigations, and this is occurring in conjunction with a dermatological immunotherapy related adverse event on a background of recurrent HCC. And perhaps I'm not sure if and it should be included in the slides that were circulated as well, whether the timeline of his presentation and manifestations would have helped us narrow down our differentials, and what do the SR think, as in the trainees think, in terms of how we should proceed. So some of the questions that I thought I had, at the point of management was, if this is nephrotic syndrome, then what are some of the possible sort of histopathological diagnosis that we should be thinking of? Any thoughts from the ground, or any further questions? Feel free to ask.
Any thoughts, any thought, or any comments? You can share with us, or you can text in the chat. Whatever.
Arthur, is it? Arthur, you have a question? Raise your hands.
Hi, I'm Arthur from Southern Philippines Medical Center. Doctor, just regarding the history of the patient, I just wanted to check why the albumin was given. I was also considering a cause for the AKI possibly could be HRS if in the background of the HCC. And on the nephrotic syndrome, I agree with the differentials, and I saw the PLA2R was also included in the workup for membranous. I just wanted to add FSGS as well, given the immune checkpoint inhibitor use in malignancy.
They are good thoughts. The albumin was given by the oncologist, so that was before the patient was referred to us. So at the time, he was still minimally symptomatic, and at the background, I think we didn't give this information, but he does have cirrhosis. He's a Charles A, so it's not a Charles C. Probably not someone that we think will kind of have unprovoked HRS, so to speak. So he came in with I guess seemingly abrupt onset of lower limb swelling. I've indicated 3 days of what the patient has volunteered. But if we look at the trend, it does seem like the albumin has been downtrending for some time prior to his symptoms. And maybe it's just a question to the trainees again. Does the trend sort of help us narrow down our differentials as to thinking which is probably the most likely cause of his presentation? Maybe any trainees from Singapore who want to kind of join in the discussion as well.
Yeah, no one know the answer. Please get it engagement. Usually it's not too tough for
It's not-
people, I guess.
Okay.
Actually, I don't know.
Okay, Julian, maybe you go to the next slide.
Yeah.
Yeah, so the abrupt onset would usually make us think of minimal change, I think. But when you look back at the albumin trend, there is actually a slow decline, a gradual decline over months. I would say maybe 6 months prior to presentation. And if you ask the patient a little bit more clearly, he does have frothy urine starting from April. So despite the edema manifesting almost like a seemingly abrupt onset, but it would suggest that this is more of a subacute kind of manifestation. So in my opinion, at that time, membranous nephropathy seemed more likely than minimal change. But without a biopsy, we can never confirm. So very ideally, we should kind of obtain a histological diagnosis or confirmation of what we're dealing with. But the patient is 87. He has shared that if possible, he would not like to undergo something invasive, which is something that's not unreasonable. So it creates a little bit of a dilemma whether or not we should recommend strongly for a biopsy. And then if not, how can we best manage his nephrotic syndrome at this stage? Yeah, so these are some of the thoughts. And I think some of the other questions for the trainees would be that I think people have kind of brought up the fact that the patient was on immunotherapy and whether immunotherapy could have unmasked underlying glomerulonephritis. So again, I think if we were to highlight, maybe if we go back to the slides again, yes. So the albumin decline seemed to have predated the exposure to immunotherapy. But we can probably, we won't be able to deny a possible contribution from the immunotherapy in terms of modifying the disease trajectory? You know, was it something that caused the patient to kind of manifest a little bit more abruptly as a result? I think these are questions that we may not have answers to, but these are some good thoughts because we note that some of the trainees have are now aware of possible renal immunotherapy side effects. So that's the second point that we like to make. And maybe the third point is the fact that the patient has a history of hepatitis B, but is now almost virally, you know, almost completely virally suppressed. So very, very low hep B titers, and is on regular sort of entecavir. Yeah, so I think I will now hand the time back to Julia, who will now go through some of the sort of data to address some of these questions in more detail. Yeah, Julia.
So actually, we suspect membrane pattern, right?
Yes.
So, and because the patient have so many underlying disease and also have concurrent skin lesions, so probably it's secondary membranous nephropathy. And we are waiting for anti-PLA2 receptor in the body, right? So I guess it's negative. But we don't actually have many evidence about the new immunotherapy. But I guess maybe related to drug or maybe the recurrence of hepatocellular carcinoma. Probably because the viral load is very low of the hepatitis B virus. So I probably is related to secondary, but probably is a hepatocellular carcinoma and or maybe immunotherapy.
Yeah.
And
So
you're
that
gonna
will,
proceed to biopsy, or you need to ask any opinion on that?
maybe we can ask the audience.
Adrian, you join us. So any thought from you, Adrian? Love to see you. Please unmute yourself, Adrian. My dear friend. Nope, okay. Okay, Dr. Julia, please go ahead. Sorry to interrupt you.
Okay, thank you. Okay, so yeah, so these were essentially our considerations. So I'll go through a little bit of the discussion points. So firstly, I mean, so this basically shows the hypothesis for the proposed pathophysiology of membranous nephropathy in malignancy. So firstly, you can see here antibodies may be generated against a tumor antigen that is identical to or bearing an epitope that is similar to an endogenous podocyte antigen, thus leading to in situ immune complex formation. Then subsequently, or alternatively, shared tumor antigens may form circulating immune complexes that become trapped in the capillary wall. Subsequently, tumor antigens also may become planted in a subepithelial location where they react with circulating antibodies at a later stage. Lastly, extrinsic processes such as infections with an oncogenic virus or autoimmune function could also potentially cause both malignancy as well as membranous nephropathy. So, so this figure shows or assumes a causal relationship between malignancy and membranous nephropathy. So membranous nephropathy is usually typically diagnosed after proteinuria and or nephrotic syndrome that has prompted performance of a kidney biopsy. And malignancy is usually detected before A or simultaneously with B with the diagnosis of membranous nephropathy, but may be found afterwards in C in approximately about 20% of the reported cases. So recurrence of malignancy may give rise to proteinuria in a shorter time frame, owing to prior sensitization of the immune system against tumor antigens. And the subclinical presence of malignant cells and shed antigen potentially could continue to perpetuate the glomerular disease and proteinuria despite an apparent clinical remission of the cancer. So this is a nice case report that was published in NEJM of a 40-year-old woman who presented with THSD7A associated membranous nephropathy. She also had mixed adeno-neuroendocrine carcinoma of the gallbladder. So the primary gallbladder tumor and the lymph node metastases were positive for THSD7A on immunohistochemical analysis, which we know is strongly associated with malignancy. Basically, you can see here that after chemotherapy, the THSD7A antibodies in the plasma were no longer detectable, and the urinary protein excretion also decreased from 5 to 0.7 gram per gram. So this is a nice case showing the cancer-associated membranous nephropathy in the case that we have antibody, a serological antibody that we can test in the serum. So this is a summary of published reports of membranous nephropathies associated with ICI. So now we are flipping a bit to the ICI group. So a number of them did have MN-related or membranous nephropathy-related antibodies. 6 patients actually in total out of 12 had PLA2R positivity, either in biopsy and or serum. One had THSD7A positivity, and another had anti-NEL1 positivity. So just wanted to, so this is basically a summary of all the case reports at that point in time. Most had the ICI discontinued and had additional treatment in the form of steroids, and 6 had additional rituximab given as well. The treatment part of which I will come back to at a subsequent point. But this was just to show the number of patients that the types of cancers, as well as the number of patients who had MN-related antibody positivity or negative.
So I think this is just to show that, membranous nephropathy has been associated with immunotherapy exposure. But in our patient, it's also quite likely that the membranous nephrotic syndrome was present before the exposure to immunotherapy. But whether or not it has kind of like worsened the control, it is something that is still theoretically possible. Okay, next slide.
Thank you.
So yeah, so I think we have gone through some of these questions, but maybe just to also fill in the rest on his progress in the interim. So we can see that since he was admitted, his creatinine has continued to rise. And of course, this is in the context of us being diuresing him quite aggressively because he was quite edematous. I think earlier on, someone did bring up the interstitial nephritis subtype of renal IRAE. This is something always on the back of our minds when we are dealing with AKI in this context. So a biopsy would be really helpful because it would help us confirm the etiology of nephrotic syndrome. Although the morphology will not help us or will not inform us of the trigger, it would also kind of help us exclude any sort of interstitial nephritis, given that we are seeing now progressive kidney dysfunction. But it is it's very likely that it's related to our diuresis. So I think we did kind of bring up the dilemma because the patient is quite elderly. He's 87 years old. So maybe question back to the trainees as well, as in what are some of the considerations for performing kidney biopsy in the extremes of age? Then what would you use to guide whether the
apology, Dr. Tan, for the time frame of creatinine and also proteinuria is consistent with the treatment with the immunotherapy or not?
Which one is, sorry?
For time frame of the proteinuria level, and creatinine is consistent with the immunotherapy treatment or not. I'm not quite sure
Yeah,
how many
so-
times you give
Yeah.
that.
Yeah. So I think he had about 2 cycles. So what he's on is actually a dual checkpoint. So for dual checkpoints, hyperacute IRAEs have been described. I mean, in terms of AIN. So hyperacute usually means after a single cycle, which is seen like in maybe 3 weeks after first cycle of immunotherapy. Yeah, so we are talking about this patient manifesting maybe like 1 to 2 months, within 1 to 2 months of initiation of immunotherapy. Yeah, so timeline, yes, is important. But as with most of the RAEs, I think there are exceptions to the rule. So the timeline may not necessarily kind of exclude some of these as differentials. And I think for the membranous part, we kind of established that nephrotic syndrome kind of happened before, although he remained minimally symptomatic. With regards to the the severity of AKI, I would say that, you know, this is not usually what we see in the AIN subtype. Tend to be quite aggressive kind of AKI, almost like an RPGN kind of picture. So this one was like a creep, which was more consistent with a diuresis type of creatinine, and we were also trying to give albumin concurrently. Yeah, so I think hope that answered your questions. And if there's any other questions from the audience, please feel free to
I
raise
want
your hand.
to hear any thoughts from the other country besides Thailand and Singapore. Any from Malaysia or Australia? Maybe I have to apologize for Australia. Maybe the time that I indicate in the flyer is maybe not correct for Australia. And any thought or any comment or any experience on immunotherapy or anything about this case before we go to the biopsy pathology?
Hi. May I know, was Antipla was done? Antipla.
Yes, it was pending. So yeah, so it runs every Tuesday when at our institution once a week. So the patient came in on Tuesday, so the only time we will get the result is a week later. So we have to kind of make the decisions without the results at that time. Yeah.
Okay, time to review. I think no one comments on that. So time to review the pathology, right? So no contraindication for the case. I mean, contraindication to kidney biopsy. If no, we can
no,
pursue.
not really. Yeah, so not really, because despite the age, yeah, his baseline creatinine was good. I mean, parenchymal thickness was actually normal on imaging. So technical kind of challenges were kind of we didn't think there was much of that, and the interventional radiologists were very happy to proceed. Yeah,
because of hepatocellular carcinoma and maybe cirrhosis, we have to check coagulopathy before.
Yeah, so because he's a Charles A, so there were no coagulopathy.
Yeah,
and
all right.
platelets were also okay. Yeah.
Yep.
Okay, Julia.
Okay, thank you, everyone. So just wanted to go quickly into the different etiologies, or rather, different etiologies of malignancy-associated nephrotic syndrome. So this one here, this paper shows the different etiologies and the types of solid malignancy tumors actually that they are linked to. So the first row here with membranous nephropathy, you see that actually majority of them are the respiratory tumors, digestive tumors, subsequently urological, gynecological, and others. And then membranous forms the bulk of the types of GN associated with in nephrotic syndrome with solid malignancies, following which would be things like MCN, MPGN, and FSGS. So this paper, we just wanted to highlight basically before the era of antigens such as THS-D7A, we didn't rely on histological parameters in determining cancer-associated membranous nephropathy. So in histological parameters here, you can see that in the cancer-associated MN group, actually, inflammatory cells for glomerulus actually was a good indicator in terms of differentiating cancer-associated MN versus the control. This subsequent paper here also showed that biopsy-proven MN with IgG4 predominant stranding for idiopathic MN or primary MN with 95% having IgG4 staining here versus a secondary MN or malignancy-associated membranous nephropathy had staining in other IgG subclasses.
Julia, I will go through the slide. Yeah, so I think we are really now at the management part because it's been like, maybe 3 to 4 days after the admission, and patients was very, very undecided about the biopsy.
Because it's time limited, is it better to skip to pathology? And
Pathology.
do you have the pathology slide, right? So I can
Yes,
give
yes.
like a
we can go
to read it for a while. Yeah. And then we go back to the patient.
Oh, okay. So you want to skip this part, is it? And go straight to
Because we have only 1 hour, so
well,
it's only
no
20
problem.
minutes left.
So maybe Julia, we go to the next slide.
So eventually patient was So we did mention that the patient initially was undecided about kidney biopsy, but so he was leaning against. Subsequently, we did discuss with the patient, and he was agreeable for empirical treatment of nephrotic syndrome with a presumed malignancy-associated MN, and he was offered a rituximab monotherapy. And other agents such as calcineurin inhibitors, prednisolone, cyclophosphamide were deemed less suitable. He was planned for IV rituximab inpatient on day 6 of admission, but subsequently he changed his mind because of other reasons, and kidney biopsy was discussed. He was eventually agreeable at this point, and so hence he underwent kidney biopsy while waiting for the daughter to come back. This is basically the kidney biopsy. Maybe would some of the trainees like go
to the next slide. Maybe we'll go to the next slide.
Anyone want to volunteer to read the pathology? Anyone from Malaysia, Indonesia, Philippines, or maybe Thailand again? No, if not, so maybe Salit from my university volunteer or win. Anyone of both of you can join reading the slide, or either one of you.
I'm Dr. Sarit from Chulalongkorn University. So the pathology of this case, I can see the
I interrupt you for a while. Dr. Andres, how many slides did you have? So we can
it's okay. We can slow it. We can speed through some of these things. I think 40.
I think 40.
Yeah.
14. Okay, 14. Lalu, we have 14 slides, so please read it real fast.
So
go ahead.
Okay, so from the picture above, like we can see that there is a thickened glomerular basement membrane, and also there is a increased cell. I'm not sure whether it is a foam cell or not. And
what is the stain color? What is staining?
It is a head PAS.
PS staining, and describe the PS staining.
Yeah, so this is a PAS staining, and we can see the thickened glomerular basement membrane, and also there is like a cell inside the endocap, and the endocap hypercellularity. I'm not sure whether it is a foam cell or not, and the mesenchymal is there is no cell increase in mesenchymal
Is it a
area.
resident cell or is it an inflammatory cell that infiltrate in the capillary?
I think it is the neutrophil, so it may be the inflammatory cells.
Okay. Go.
Oh, wait, so next
Next slide, please.
picture.
I think next slide, please. Next slide, please, Dr.
Sorry.
Andres.
Oh, sorry. Yeah.
Oh, only one slide. Okay, I thought I have so many slides. Okay. So if you see only one slide, what is your early diagnosis? Dr. Andres, go back. Now you have the list of
from the picture above, like is a light microscope that show the PAS stain. So we can see the significant thing that is a thickened glomerular basement membrane. So my diagnosis is like from the pathology and the clinical. So I suspect the membranous nephropathy.
Yeah, it is secondary or primary.
It's
And
a
why?
secondary.
And why?
It's a secondary membranous nephropathy because
You suspect the secondary membranous nephropathy, right? Because what?
Yes, because there is some degree of inflammatory cell, so I think it's gonna be there secondary membranous nephropathy.
And how you differentiate or make sure that it's secondary, and from what? What else that you want to see from the pathology?
So we have to look at the electron microscope to see whether there is the electron deposit inside the mesenchymal. If there is, they're gonna be the secondary membranous nephropathy.
Is immunofluorescence help you?
And the IF as well, we have to look at the mesenchymal area as well.
Okay. Dr. Andres, maybe next slide, please. Or maybe you want to add anything or any comments on light microscope before going to immunofluorescence? If not, so okay. Dr. Salit, please go ahead and continue. Oh, what is the immunofluorescence that showing the slide? Is it IgG, right?
Yes, it's
IgG staining, right?
Yeah.
IgG, okay.
From the
Salit, continue.
Okay, from the IF, from the immunofluorescence staining, this is the IgG, so we can see the granular staining at the endocap. Inside the capillary wall, and the strength of the staining could
inside
be
or outside, in or out?
Outside the capillary wall, and the strength of the staining could be like 2+.
How do you know it's in? How do you know it's outside or inside?
The type of the staining is like we can see that there is a smooth surface outside the staining, so it should be the extra capillary.
Okay.
Wall.
Beside GBM, which area that have immunofluorescence staining?
There is some degree of the staining inside the mesenchymal, just some area of the glomerular of this glomerulus.
So when you read the immunofluorescence for issue or for item, that you have to describe the which staining and pattern of staining, intensity, right?
Yeah. So the intensity is 2+ for this GOM.
So it's a GBM and mesenchymal staining for 2+ or 3+.
2
And
2+.
granular staining 2+. Okay, only IgG, right?
Yeah,
And
only
how about
IgG.
the left electron microscope? Is it confirm your diagnosis?
So from the electron microscope, the picture above show the thickened GBM with the thickness of 504 nanometer. So there is a thickened GBM as we supporting the LM, and also there is a sub-epithelial electron deposit.
Sub-epithelial, right? Sub-epithelial.
Sub-epithelial, and also
So
there is a food process of the podocyte
it's
affected.
confirmed membranous nephropathy, right?
Yes.
And you see anything else in the electron microscope picture? Okay, I will give the Singapore Dr. Tan to cover that because it's only 10 minutes left.
Yeah. So I think we can go through, I mean, I think the trainees probably identified some of the very important findings. Julia, maybe you can bring us to the summary of the histology. Yeah, so I mean, I think the trainees have rightfully pointed out some of the capillary loops are thickened. The report actually states that there was really not much significant sort of interstitial infiltrate. There was no suggestion of AIN, and there were minimal sort of chronicity changes. IMF was consistent with membranous nephropathy with positive staining of IgG and a strong IgG and C3 staining. And EM showed diffuse effacement of podocyte food processes, as well as large amount of subepithelial electron dense deposits. So we also went on to perform the PLA2 R stain, which was negative. We did have some sort of research stains that are currently not validated, but they have also returned negative, and we didn't have the subclass stain in our institution. So maybe in the interest of time, we will now kind of continue on to the progress. But essentially, the kidney biopsy confirms the diagnosis of membranous nephropathy. And in this clinical setting, we did think that it was secondary, possibly malignancy associated. Yeah, so very unfortunately, 1 day post biopsy, he developed fever and chills, and then had septic shock with oligo and uric AKI. He actually grew, I mean, he actually developed septicemia from Enterobacter bacteremia, although the CT didn't identify any local, no obvious source of infection. So the source was eventually deemed to be gut translocation, since he did have quite a bit of gut edema from the nephrotic syndrome, and he was started on dialysis as well as IV antibiotics. So actually, before this happened, we were going to immunosuppress him. So now the clinical question is, and we have chosen rituximab as the choice of agent. And now the clinical question is whether we can proceed. And if not, when do we do it? And if we do, how do we mitigate the risk of infections? Any kind of quick opinions from or comments from the ground before we move on? Any questions from or comments from the attendings or consultants in the audience as well?
Anyone to comments on I saw Dr. Iqbal, but I'm not quite sure where he is now. And maybe a bit difficult case, so that's why people try to just listen to you.
Okay, next slide. So I mean, basically we will proceed with I mean, in any patient who's going to be receiving rituximab, we will give routine prophylaxis. Usually we'll give a PCP prophylaxis, and we will advise on some precautions for infections, and in this setting we would also be interested in checking the immunoglobulin G, since the patient also has nephrotic syndrome. And you can, and there is expected proteinuria loss of immunoglobulins. So you can see that his IgG is a little low at 4.39. So I guess the clinical question is then, if we were to proceed with rituximab, do we give it with IVIG? Any thoughts?
Maybe people all agree with you.
Okay, I mean, I think maybe we will just have a quick look at the guidelines if there's any. Yeah, so there is actually a practice guideline for secondary hypogamma. They do recognize protein losing conditions, such as nephrotic syndrome, but there is no specific recommendations for patients with membranous nephropathy. But you can see that there are some recommendations for things like CLL, ANCA, SLE, and also rheumatoid arthritis. Okay, so next slide, please. And if you look into some further details in certain patient subgroup, especially the ones with hematological conditions, you can see that there are some sort of accepted threshold for IVIG use, which would be IgG level of less than 400 milligrams per deciliter, or if there's IgG that's more than 400, but with life-threatening infections or serious infections given the time frame. So in our center, we usually give it only if the infection is difficult to control. So it's not necessarily kind of indicated in all cases. And then next slide, please. So we're trying to see both sides of the coin here. So essentially, evaluation of hypogamma can be complicated by the use of immunosuppression, right? So it's both the rituximab and as well as the disease contributing to the extent of hypogamma in our patient. I mean, in general, in patients with nephrotic syndrome. So our patient already had hypogamma prior to receiving rituximab. So they both confirm probably are associated with increased risk. But again, this is not the only factor that determines patients' infection risk in general. So there is some studies looking at
Dr. Tan, can I interrupt
Yes.
you for a while? Because
Yes.
the time limited, so I'm gonna tighten up you.
Yes.
And it,
So,
yep.
So we'll summarize.
Yeah, please.
Yeah. So Nick, maybe just one the one before. So just very quickly, so IVIG, even if we give, is quickly lost in the urine, and some IVIG also have nephrotoxic concerns. So just to sum up, this about the use of IVIG in this context. So next slide. So we did end up giving, partly it's because patient was also anuric, and perhaps would have stemmed the loss of urinary loss of immunoglobulins, and the IgG remained quite stable. So He received 2 grams of rituximab in total, got PCP prophylaxis, weaned off dialysis a couple of months later, but unfortunately had 2 more episodes of infections. And then we can have a look at his progress at this point of time. The next one, next slide. Yeah, so in the interest of time, his AKI is resolved. He's almost back to his baseline. His albumin uptrended, but it's currently hung at 28. And his UPCR is about 2.5. And of course, his immunotherapy has been withheld since then. So in essence, we think that the rituximab did address the nephrotic syndrome, which is due to a biopsy-confirmed membranous nephropathy, which is probably secondary in nature given patient's history of hepatocellular carcinoma.
Yeah, great. So before we closing, can we take a group photo? Anyone any comments? Or
any
anyone
last
to
comments?
answer question? Last question for Dr. Tan. Because it's an honor to us that you give a very wonderful. No, if no one.
Just to
Okay.
tell the trainees that in such a situation whereby there's already, I mean, the nephrotic syndrome actually predates the immune checkpoint inhibitors, right? So patient is probably already at risk. And so when you give immune checkpoint inhibitor and you lose self-tolerance because of the immune checkpoint inhibitors, that's when something that's already ongoing may just become worse. So I think that's something to think about in this case that needs to be thought about if, let's say, and as a trainee was involved in the earlier discussion with oncologists as to whether or not to give the immune checkpoint inhibitor. Adrian got hands up. Adrian?
Yeah, thank you, Dr. Jason, for your wrap up and take home message. That's really important point. So before closing, can we please turn on your camera or your video so we can take a group photo before we leaving?
Sorry,
Please.
Golf. Can I just give a comment?
Adrian. Yeah, of course, Adrian.
I think we just need to be a bit cautious that that we just have to be very certain that the idea is that rituximab is not given for every single membranous nephropathy, especially this is a secondary membranous, and that rituximab is mainly indicated in the primary membranous. It has been given in some cancer-related membranous and immunotherapy membranous, but more importantly is that I think it is almost considered if you're going to use rituximab in someone who is hepatitis B positive, it is actually part of the Asia Pacific guidelines that it is at a high risk of hepatitis B reactivation. The other thing that while everyone assumes that this is HCC related membranous, you cannot exclude the fact that this could be hepatitis B related membranous. And especially if the patient is on entecavir and you're still finding a detectable viral load, I would be very, very cautious about using rituximab. And so it should not be considered the first line treatment for cancer-related membranous nephropathy or even other secondary forms of membranous, including an immune checkpoint inhibitor. So that is something that needs to be taken in caution.
So
Thank
unfortunately,
you.
in the
That's an
interest of
important point.
yeah, in the interest of time, we didn't have the time to deliberate all these considerations, which were in kind of like in other slides as well. So thanks, Dr. Liu, for bringing those things up.
Yeah.
So maybe because some people may leave early, so maybe please give ask your permission to publish the record webinar, and we're gonna publish in the iSend or maybe in the YouTube. So please anyone please open your camera and your video so we're gonna take a good photo together. And while waiting for open the camera. So I would like to thank you all for being here and for your active participation, and special thanks for Dr. Tan It's a wonderful case, and Dr. Andres for the insightful presentation and also extensive review, and we got the time limited. So next time, please feel free to share this experience with your colleagues, and we look forward to seeing you again at the next CPC.